For this lecture, we're going to talk a bit about assessment, intake, and the biopsychosocial history. When I am talking about assessment here, I'm not only talking about validated measures as assessments, I'm also just talking about using the interview, the clinical interview, as a time for assessing your client's level of functioning and needs. So let's keep that in mind as we move through. I've also been talking with Dr. Bigelow, and as I understand, you guys will be covering intake quite a bit during residency, so we won't spend too much time on that. Nonetheless, you do have an assignment this week or an activity this week where you will complete, so sorry about the dog. As I was saying, an activity this week where you will complete a mental status exam form based on your assessment of a client's functioning and presentation based off of a video that I'm assigning you guys. So this will set you up to do that activity as well as understand the parts and pieces of the mental status exam and how we use that as our assessment of functioning in the counseling session. I've got a few more clinical abbreviations here for you that you are likely to see in case vignettes or in, medical charts. So feel free to adopt these, but now at least you'll know what they are when you come across them. So as I mentioned, when we're talking about assessment, we are not only talking about formal assessment as in tests and measures, we are talking about gathering data and information about our client from really a variety of methods. And so, of course, you'll have a whole class on assessment when we refer to more formalized assessments like tests and measures. But it's more likely that you will be using other forms of assessment as well. So of course, when we are assessing a client, we are trying to organize information about them, about what's currently going on, about their history, gather some information about the family, so that we can try and understand the etiology of their concerns that they're bringing in, possibility of where this is coming from, what's maintaining this. Are there any stressors or triggers that have precipitated this event? And how can we get that under control, right? So this is why we ask about in the intake all of the different areas that we ask about, including current functioning, family history, social, occupational, educational history, social supports and relationships, right? We ask about all of these domains of information to try and put this puzzle together. I really like to think of this part of the clinical relationship and this clinical piece as a lot of problem solving. In a way, you're kind of playing detective of trying to put this puzzle together and figure out what's going on with your client. And, it can be like problem solving. It can be fun. All right, so 3 modes of assessment: observation, interviews, or tests and measures. Of course, observation, when we're doing a formal observation, this would tend to be highly structured. You can also do informal observation. So formal observation would involve really, because it is so structured, it would involve counting and tracking behaviors where you are establishing that baseline for intensity and frequency, duration, and you are systematically observing change in these behaviors from baseline to, continuing different points in treatment. We can also do informal observation though. So, for example, this might look like observing children on the playground. When I was working as a children's therapist, I would frequently see my children at the schools, and one of the things that I would do to gather data about how well or not well they were doing would be observing them play on the playground. How are they getting along with their peers? How are they listening to, their teachers and other authority in the school, right? So you can have both formal and informal observation. And of course, the more informal observation tends to be more natural, naturalistic, whereas formal observation does tend to be much more systematic, structured, and controlled. Um, Obviously, observation is a huge part in behavioral therapy and anything that we're doing to change behavior, okay? Interviews. This is what the intake is. The intake is just one really long interview covering lots of different domains. Again, here you can have both formal and informal interviews, right? So, for example, the SCID is a structured diagnostic interview. It has very specific questions that you ask in a specific way to elicit answers. On the other hand, you can have informal interviews that are maybe not as structured and more conversational. When you are doing these interviews, though, which, by the way, interviews are one of the primary ways that we gather data as counselors. When you are conducting interviews as a form of assessment, it's very important to pay attention to everything, every aspect that is there in the room with you. That includes verbal cues, nonverbal cues. That includes appearance and dress, style of speech, timing of speech, et cetera, which we're going to jump into quite a bit more as we move through this lecture. And then finally, the last type of assessment, as I mentioned, tests and measures, which of course these really stress the importance of standardization, and typically these have been validated or proven reliable or not, and they've been normed to a specific group or a specific sample. And that's really important to pay attention to when you are giving a formalized assessment, is looking at that norm group, right? We don't want to use a formal assessment that has not been normed on the group or the population of the client you're working with, okay? Let's see. Okay, that's the overview of types of assessment here. Let's talk just a bit more about the interview assessment. This is typically what you're going to use perhaps in concert with a measure or standardized assessment in order to make your diagnosis, right? You will conduct a diagnostic interview. You may be able to gather that data from your intake, right? So let's talk about this a bit more, because this is a likely format that you will use, okay? So I want to note that there's not like a standard set for intake. It's the set and format and flow of intake really varies by setting and agency. Each agency is going to adopt their own process and procedure for intake, as far as what questions are asked, which domains do we tap into, who is present for this interview, et cetera, okay? So it's going to look really different. The intake that might happen, or the procedure for intake that might happen with school children versus prisoners in corrections. Some things that you have to think about with your interview assessment. One moment. All right, so some things you really have got to think about with the interview assessment, as well as other forms of assessment, is who will be present, who are you going to gather this data from? Obviously, if it's a minor, we might need to have a parent present. My cutoff for that typically is, if the child is between 10 and 12, we can start considering using the child themselves as a primary source of information, right? They're, at that point, trustworthy enough, more or less, to provide their own self-report information. But typically, if I'm working with a child under 10, I really, rely more so on the parent or guardian or caregiver for that information, right? So who's going to be present? In addition, you got to think about level of functioning and trustworthiness, right? So if someone's in the middle of a psychotic episode, and they have poor insight or poor judgment, right? They have poor awareness about their own illness. You are unlikely to use them as your only source of data, or you shouldn't, right? You are going to need to work with others in their social networks in order to help you gather the data and information that you need to make an informed diagnosis, as well as to inform your treatment. What areas are important to probe? Again, that is going to vary by agency and setting. But of course, what's typical, I kind of mentioned current presenting concerns, family history, medical history, education, occupation, legal issues, um, past instances of treatment or issues. So it kind of is very expansive, the domains that we want to be sure and hit. Your intake form, whatever the form is that you're using, will typically dictate what questions you're going to ask as well. And again, I mentioned some of those are going to be more standardized with very specific questions that can't be changed, and others are more conversational and allow room for the clinician to kind of come up with questions on the fly as they become necessary. Okay. And how are we going to document the intake interview? Well, the intake is a pretty large piece of documentation, right? Because it contains all of this information. It's quite a large document, and I'll post an intake summary for you guys that has been de-identified so that you can see. But typically, you're going to have about a paragraph under each of these domains that you're assessing for. And of course, you want to use direct quotes as much as possible. And this is why when we're writing the case conceptualization, we do want it to be shorter. We want it to hit the high notes of the intake, but see, you have all of this information in the intake that someone could go back to gather more information if they should need. But this is why I typically stress a shorter case conceptualization, because you're just wanting to hit the high notes of that intake or that interview and assessment that you've done, that again will inform your diagnostic impressions, your working diagnosis, and treatment from there. You may also hear the intake referred to as a biopsychosocial history. In some of the settings that I've worked in, they did not refer to it as intake. It was referred to as the biopsychosocial history instead. So again, you may hear these interchangeably, and these are the major sections, as I've been talking about, of a standard intake or biopsychosocial history. And that mental status exam is a particular piece of an intake or a biopsychosocial history. So we'll talk about what constitutes that mental status exam specifically. And of note, that mental status exam, which is actually on the next slide, so I'll just wait to discuss that then. All right, so as I was saying here, the mental status exam is where you can have a mini mental status exam. It's a set of questions that helps us, or prompts that helps us measure or gauge, again, our client's level of functioning across multiple domains, which we'll go over one by one in a moment. But typically what you'll see is that you'll fill out a mental status exam at intake, and most agencies will want you to fill out a mental status exam at each session as well, so that we can, again, have that data of the client's functioning at multiple points throughout the counseling relationship and treatment, okay? So just note that this brief assessment piece, the mental status exam, you will use throughout the duration of treatment, okay? And so one thing that you are doing as a clinician is you are evaluating your client based on their responses, right? Is this response appropriate given the context? What is standing out to me about this client's responses and the way that they are engaging with me? One of the things that you are going to be asked to evaluate with the mental status exam is appearance. So you're definitely going to want to pay attention to the client's appearance as it relates to their posture. Are they slouched over? If they're, for example, if they're completely slouched over the whole time, we might make some assumptions about perhaps their mood, or maybe they're in a stupor. Perhaps they are intoxicated, right? You're going to want to pay attention to their gait or walking, right? that can certainly have some implications as well, right? If they're stumbling, perhaps they're intoxicated. If they are shuffling really badly, perhaps they are having some side effects from their antipsychotic medication, right? So that's another thing to pay attention to is gait. Of course, their choice in clothing is very important. If they're dressed in a manner that is very promiscuous, or, perhaps someone shows up for their intake assessment in a cocktail dress or a ball gown, and obviously that's not appropriate for the setting, but that's important data. Perhaps they are in a manic episode, right? You're going to want to pay attention to their grooming or lack thereof. Is their makeup appropriate for the setting, right? Are they looking particularly unkempt? Is there any odor, right? This is allowing us to kind of assess for those activities of daily living, which you see referred to as ADLs, right? So are they able to take care of themselves? So again, appearance is one of those things that gives us a peek into their ability to care for themselves, or perhaps where their emotions and thoughts are at that time. Of course, we want to attend to our clients' behaviors, our patients' behaviors, and we want to make note of these things here, particularly, of course, eye contact, their ability to follow your commands. Definitely look out for any kind of psychomotor agitation, or perhaps any facial grimacing. Facial grimacing, kind of like you see here, is a very important one to pay attention to, because facial grimacing can be an underlying thing that we see accompanying multiple disorders, which again we'll talk about as we move into this, move into the class a bit more. I will tell you, I'll probably be recording some of these lectures with videos, because some of it's going to require that maybe you see me so I can show you an example of what some of these look like. But again, you will be attending to that behavior and noting anything that is odd or out of place for the setting, okay? You're going to attend to the client or patient's attitude. How are they interacting with you in the assessment or interview, right? Are they cooperative? Are they hostile or volatile toward you? Do they act like they're perhaps paranoid or being very secretive? Are they avoidant of this? Are they seeming very apathetic, right? All of this can give us clues to, again, what is a potential working diagnosis for this individual. And again, as we are doing this mental status exam multiple times throughout the trajectory of treatment, it gives us, several data points to compare, right? Perhaps at intake, they were very defensive, avoidant, and paranoid, which might be a cause for concern for certain things, but maybe we can show after 6 weeks of therapy, they are much less defensive and paranoid, perhaps, than they're cooperative and open, right? So we can see how these things are changing over time. You're going to want to pay attention to their relative level of consciousness. Are they conscious? Are they unconscious? Are they in a state of delirium, right? Do they seem confused? Do they seem really lethargic or drowsy, right? Do they seem like perhaps they're a little too alert, right? These things can all be very important clues for us. Attend to the client's orientation, okay? And what I mean by this is that the client understands where they are and what's going on, right? If they're oriented to time, that means they are aware of what time it is, what time of day it is, maybe what day it is, what year it is. If they're oriented to place, then they can tell you where they are. If they're oriented to person, then they can tell you who they are and who you are. If they're oriented to the situation, then they know what's going on and why they're there. But if they're missing any of these pieces, that's a big red flag. Oftentimes, if we know that someone is oriented to all of these things, there's no issues in their orientation, you might see it noted in the chart as oriented times 4. Very important that we check for this orientation. They're not going to be, many of these, I will note, are not going to be direct questions, right? This is going to be based on your observation and your interactions from the interview, okay? And same thing with your the mental status exam that you know, conduct at the end of every session. You're not asking specific questions about that. You're basing these, you know, you're basing your judgment on your interactions with the individual throughout whatever it is that you were doing, whether that's intake or your regular session, etc. Definitely going to want to pay attention to your client or patient's speech. You're going to want to pay attention to how much they're talking, the speed of their speech, the volume of their speech, how loud it is, the fluency and rhythm, right? And how quickly or lack thereof that they are able to respond. Okay, so when we're looking at how much they're speaking, this is very important. If they're overly talkative, this might be a sign of, you know, perhaps a manic episode or someone who is very anxious, right? If they're having a paucity of speech or they're muted, poverty of speech, that could indicate something else, right? If they're having limited speech, perhaps they're in a major depressive episode, or perhaps they are, you know, have selective mutism going on, or maybe they're in a catatonic state, right? So there's some important indicators there. Paying attention to rate. Are they speaking really fast? Are they speaking, you know, more slowly than normal? Pressured speech. Okay, a lot of people have a difficulty understanding what that is. If someone is using pressured speech, then it seems like they are just really pressured to get the words out. They just seem like, you know, they can't seem to get their words out fast enough, right? You can tell that their speech, they're trying really hard to get that out. Looking at the volume or tone, are they speaking too loudly for the setting? Like maybe they don't have that awareness about themselves. Maybe too softly, too weakly. Maybe they have a flat tone or volume to their, you know, their speech. Again, looking at the fluency and rhythm, here's some things that you might see there. And then response latency, of course, as I mentioned. One more note on pressured speech. So pressured speech is commonly seen as a symptom of bipolar disorder. So when you have pressured speech, you have an extreme need to share your thoughts, your ideas, or your comments, and it's often part of experiencing a manic episode. So speech will come out very rapidly, and it doesn't stop at appropriate intervals, right? It just keeps going on and on and on and on, okay? Just wanted to describe that one a bit more. You're going to want to attend to your client or patient's emotions, okay? Looking at their mood. That's pretty easy for us to understand, right? We are kind of in the business of looking at mood, right? We've got lots of different descriptors for mood here, and I think we pretty much know what those mean. Affect. Affect is more momentary, right? Like where mood is something that's relatively more stable and is something that lasts perhaps a little bit longer. Affect is like the weather, okay? Mood is more like the climate. Affect is more like the weather, okay? And so, again, we want to make sure that that affect is appropriate to the situation. Are you seeing that their affect is constricted or blunted in some way, meaning that maybe they're not very expressive? Are they showing a normal range of expression? Are they flat? A flat affect would mean that someone is very monotone and flat. Their face is not making any expressions when they're talking. Like perhaps I'm telling you a story about my best friend who was murdered last week, and I'm just talking to you about it in this tone. Really slow and absolutely no expression on my face or change in my body whatsoever. We might say that that is flat affect, okay? If they're animated, perhaps they're a bit more expressive than they normally would be, um, et cetera, et cetera. Okay. Are you noticing fluctuations in mood or affect across your session, right? If we are seeing fluctuations in that, or it's not, if it's unstable during session, we might say that someone is, we might say that they are showing lability or they're labile. Okay. Are you seeing congruency between their mood and their affect, right? Are they saying that they're depressed, yet they're acting animated? That doesn't quite add up, right? If someone's depressed, we might expect for them to be a little bit more flat. And yet, if they're saying that they're depressed, but they are acting very euphoric, that would not be congruent. So we want to mark if someone is showing congruent mood and affect and kind of what they're saying and their behaviors, or is it incongruent? Okay. Let's see. All right. All right, you're going to want to attend to your client's perceptions as well. Are they perceiving things accurately? This is really looking at presence of hallucinations or delusions, right? And so if they don't have hallucinations or delusions actively, then their perceptions, we typically would say, are A-okay. Next up is thoughts, paying attention to thoughts. We're specifically looking at thought content here related to suicide and homicide, of course. Those are the two big ones, but also delusions here, because again, delusions are, oh my gosh, are inaccurate thought contents, right? We want to look for ideas of reference. We want to look for thought withdrawal, thought insertion or interruption, thought broadcasting. These are all dealing with psychotic episodes here, okay? And so one way that you will assess that, again, is what the client is telling you, the content of what they're telling you. And of course, you might need to come up with artful questions on the fly to probe your clients a little bit more. Let's see. Okay. Right. So again, our thought content, this is going to come up when we are assessing for suicidal thoughts and homicidal thoughts specifically, and if we're looking for presence or lack thereof of delusions or delusional thoughts, okay? Whereas hallucinations are the perceiving side of psychosis, which has to do with, sight, sound, sensations like that. Delusions are false beliefs. Okay, it's related to thoughts only. A quick note on suicidal ideation and homicidal ideation. And we will later in the course, we're going to have an intensive whole lecture on assessing for suicidal ideation. But when we're looking at thought content related to those, if someone mentions that they have had thoughts of suicide, you are always going to want to then assess for a plan for that suicide, the means to carry out that plan, and in relative intent, right? Like, do you actually have a drive or desire to go through with it? We also want to look and try to understand if this is passive or active suicidal or homicidal ideation. So passive suicidal ideation, for example, is when you have thoughts of suicide or self-harm, but you don't actually have a plan to carry it out. You don't actually have intent to do it. Active suicidal ideation, on the other hand, is when you do have thoughts of suicide or self-harm and you have developed that plan and you do have that intent, okay? And again, as I mentioned, we will dedicate an entire lecture just to suicide and suicidal ideation, suicide assessment later on in the course. All right, paying attention to your client or patient's insight or relative level of judgment and awareness of themselves and their own situation, right? Do they have an understanding of their illness? Like, do they know that they're sick or not? So let me just give you an example here. One area where we use level of insight to help us determine the intensity of a disorder, for example, might be hoarding disorder. And when someone is very aware that they have a problem, then we might say they have good insight or good judgment into their own problems. But if someone is an extreme hoarder and, they don't see it as a problem, they don't recognize it as a danger or a problem to themselves, then we might say that they have really poor insight, right? They don't think that they're sick or that there's anything going on, when in fact it is, okay? And obviously, level of insight has some pretty strong implications for prognosis and our ability to treat, as well as treatment compliance, okay? So this is a really important piece. Let's see. Okay, yeah, I think that does it for this slide. Further attending to judgment, client's judgment, we might ask these questions of ourselves. Has the patient or client done anything to put themselves or other people at harm? Are they, engaging in risky or promiscuous behaviors? Do you have confidence in their ability to make clear and informed decisions for themselves or not, right? And you can see, if you're thinking through all of these pieces, how they fit together to help us put together this cohesive puzzle, right? All right, let's continue on. All right, so I wanted to show y'all just one example of what a mental status exam might look like. This is what you're going to be tasked with filling out for your activity this week. As you can see, it's got many of the domains we've discussed. If there are any of these words that you don't know, I would encourage you to look them up. I'm also going to post an additional worksheet with the meanings of many of these words, as well as others that don't appear on this particular mental status exam, but others that you might see on other forms, okay? It's important that you know these particular words. So as you can see, the mental status exam has all of these areas that we've talked about, and that's what you'll be filling out for this particular assignment. Another thing I wanted to make you aware of is psychiatry.org. So psychiatry.org/DSM-5 is a host of great information for you here. We can tap into kind of the wider conversations around the DSM-5. This is the one that's set to come out next, is the DSM-5 TR. Okay. We can look at changes to the DSM. We can look at some updates to the criteria. Okay. One thing I specifically wanted to show you guys was the online assessment measures here, okay? These are also available in the large copy of the DSM in the back of the book, but you can also just look at these and access them online for free. Remember, DSM or psychiatry.org/DSM-5. So I just wanted to show this to you guys. This is one diagnostic interview that can help you in making decisions about reaching a diagnosis, okay? And so you would give a level 1 assessment first, and then based on the level 1 assessment, based on the outcomes of a level 1 assessment, you might turn to a specific level 2 assessment, right? If they're showing high anxiety, you might go to the level 2 anxiety. You might even use multiple ones of these. They even have the assessments for children here for level 2. Okay. They've got severity measures here for a multitude of different disorders as well, just to help you guys, with your diagnostic decision making, okay? We've got disability measures here. We used to have to use this HUDAS. We used to have to report a HUDAS measure with every single diagnostic impression we would make, okay? Got some personality inventories, okay? cultural formulation interviews, just a whole host of great resources here that are, again, they're free. Okay, so let's take a look here at the level 1 cross-cutting symptoms here. Let's just look at the adult one. And again, this is in the back of the DSM. So it gives you a Likert type scale to ask the questions on. You can, for these particular assessments, you can give them directly to the client to respond to themselves, but typically what you would want to do is ask these questions to them and fill it out for them, right? And then you've got instructions for scoring and how to interpret this, as well as, you know, it'll give you precise instructions on which second measure you might be looking at, okay? So really good stuff there. Let's take a look at one of the level 2s, okay? Because again, this level 1 is just helping us understand maybe what domain we might need to go to as far as the diagnosis. And then these level 2 are getting closer to a specific diagnosis. So let's take a look at this mania one, for example. This gives us specific questions related to mania, of course, looking at self-confidence, looking at happiness, looking at sleep, talkativeness, activity level, right? So this can help us, again, determine if someone is in a manic episode or not. I will be honest, we'll try using some of these during your residency week here on campus when we are going through some of these diagnostic interviews face-to-face. And some students report that they prefer the assessments. It's a nice, handy tool to have, you know, at first while you're kind of learning about this process. But I've also had other students who prefer not to use an assessment and just use their interview skills to ask specific questions to help them make a diagnosis or get the data they need to make a diagnosis. And that's what I tend to do as well. I much prefer a more informal interview. However, I will say that using a more structured assessment like this will stand up, you know, for legal reasons better, right? So for example, if you were to get called into court with your case file about some decision that you made, if you were to be able to show that you had actually done an assessment to reach that diagnosis, that would probably hold much more weight than, for example, a more informal interview. So especially maybe early on, using assessments to lean on until you really get the hang of diagnosing, that could be helpful to you guys. Let's see. Let's flip back over to our PowerPoint here. All right, so my last 3 slides here are really just overviewing the assessments that I just told you about, and I will go ahead and post this as this PowerPoint presentation to Canvas for you guys so that you can have them without the video as well. So again, we've got that HOODAS, we've got the DSM-1 assessment and the DSM level 1 and level 2, excuse me. All right, so I think that does it for this particular lecture. If you have any questions or there's something that you feel you'd like some clarification on, please feel free to reach out. Yeah, I'm looking forward to putting some of these skills to use when we're in person. Best believe you're going to be doing a mental status exam with one another and some of these diagnostic interviews with one another in real time, and that's really exciting. So I'm looking forward to that.